FPWR has initiated the PWS Clinical Trials Network, a clinical trials consortium, of which many people in this room are members, including Neil, including Fred, who's with Rhythm, who will speak next, as well as academic investigators, including Elizabeth Roof and Anastasia. And one of the really important things that we're trying to do with that is provide the information. Well, there are many things, but one important thing that we're trying to do is provide the information to the FDA that will help them be able to approve these drugs. So to convey, we've had some good, on the patient advocate side, we've had some good conversations with the FDA to help them understand PWS, understand the needs of the community that are beyond just obesity, because it would be great to reduce weight for those of our individuals who are overweight, but the bigger issue is hyperphagia and behavioral issues. And so we've been, and the FDA is extremely receptive to those things. They want to know what's most important to families and whether a drug addresses those problems. So we've put a lot of effort, and that's one of the reasons that Sophie is here, and that's why you have these surveys in your packet, is to really document what are the needs and the wants of the community, so that when Neil goes in and says, hey, it's not about obesity, it's about hyperphagia, the FDA understands that that's what families think too. So, so we're really working to continually inform the FDA of that, continually educate them, and I think it's very encouraging that I think they really do. When we had a clinical trials consortium meeting last July, there were many FDA members in attendance, so they come, they listen, they're really interested, and we will continue that process. So our last speaker of the day is Fred Feodorek. I cannot say the name, I'm sorry, Fred, but he'll correct me. And he is going to talk about the drug Setmelanotide, otherwise known as RM493, so you may recognize it by that drug, that name, and its evaluation in PWS and other syndromic obesity syndromes.
And nobody can pronounce my name right, okay? And it's just something I've dealt with for my entire life, and so I say, it's like if the hat fedora, and you just add an EK, it's Fedoric. So. No. Okay, so let me make sure I get things ready here. Okay, so it's a real pleasure to be here at this community talking about Setmelanotide, and I'm going to give an update on our program in Prader-Willi and the other monogenic obesities that Teresa alluded to. How do I move this forward? Let me just see. Sorry. This thing? Okay, so this is a single slide. For those who've lasted the entire afternoon, I'm going to try to make this brief, but this is a single slide about our drug. It is called 493 in the past, but it now has a name, Setmelanotide. And it is a new drug. It doesn't have the kind of history that Neil described, but we're doing everything we need to do to evaluate it in all the safety and toxicology studies that are necessary. So the way it works is it's a melanocortin 4 receptor agonist, which means it activates one of those important receptors in the hypothalamus that you heard about a little this morning from Lisa and Rudy's lab. And so we think that that is a critical regulator of weight, eating behavior and hunger, as well as energy metabolism that helps in long-term weight control. And so that's why we're developing it. It is a peptide, so it means that it has to be injected as a single daily injection in its current formulation. And it's highly potent, and can be administered, like I said, in a single daily dose. We have studied it in sort of healthy volunteers and also healthy obese subjects for up to 3 months, and we know there that it's at least safe over those periods of time with some particular side effects that we were looking at, in particular knowing the mechanism. The one in particular that we really wanted to find out about were cardiovascular effects, because other oral compounds targeting this same receptor really caused, elevations in blood pressure that would have and did make it impossible for further development of those oral compounds. So we very carefully studied this drug in not just patients, but also in rhesus monkeys using ambulatory blood pressure methods, and showed that there was little, if any, blood pressure elevation in these very carefully conducted ambulatory blood pressure studies. So that's very good. We've also been doing all the toxicology studies, and I'm happy to tell you that we now have progressed, that we have the chronic toxicology studies nearly finished, as well as important for this community, juvenile toxicology studies that will allow us to dose in younger patients, depending on what the results are of our current trial. Now, here is the schema of our pathway. And, again, it's really exciting coming to a meeting like this because we're going to have to update the pathway a little bit about what we're looking at in terms of its relationship to Prader-Willi, but also the monogenic diseases that we're treating. So this is what we call the MC4 pathway. Again, it's all schematic here, but it resides in the hypothalamus, and we're targeting the MC4 receptors that are in the sort of the end of the pathway, if you will. That's where appetite, energy metabolism, and ultimately weight control is controlled in a normal situation. You probably are aware that MC4 receptors, if you're missing just one of these, actually it's the most common form of genetic obesity, and so that's why we have two there. And we need to have activation of that receptor in order to have an effect on weight control, energy metabolism, hunger. We have now identified, looking at these, very uncommon, even rarer than Prader-Willi diseases, conditions that affect all of the different genes upstream, including what we think Prader-Willi is. Going into this meeting, we would have told you that MAGEL2 was the main connection to the hypothalamus, and that's why we were trying to look at whether it would have an effect on the obesity and hyperphagia of Prader-Willi syndrome. But now, hearing the results on the PCSK gene that's also there, we can actually think that since SNORD, as we heard from Lisa this morning, may be involved in impacting and in interfering with the activity of that enzyme, that may also explain why POMC, which is the originator of the ligand that activates the MC4 receptor in normal patients, is missing. So there are a lot of complicated factors that you can actually identify as single gene disorders, and that's what we're working on in parallel to our Prader-Willi work. The other thing we're looking at is there are other related conditions, including if you have just one gene that's abnormal, it's a possibility that some of those patients may be impacted. So we're looking at heterozygous states of POMC gene defects, and we're going upstream from the POMC neurons themselves, where POMC is generated as a peptide, including leptin receptor mutations as well. So this whole story, this is where you start with what is commonly referred to as personalized medicine approach. Obesity itself is so common. These genetic forms of obesity are actually even rarer than Prader-Willi, but all told maybe 500 to 1,000 in the US of some of these individual mutations. But we're really trying to understand whether these personalized medicine approaches can apply to some extreme early onset childhood forms of obesity. And I'll show you some data in our patients in the POMC situation and tell you an update then about Prader-Willi. So here's POMC efficiency obesity. Again, in this situation, as I mentioned, the genes that are knocked out are either the PCSK1 or PC1 gene or the POMC gene, and we've studied 2 patients where POMC gene deletions have been now treated with setmelanotide, and I'll show those results. It's essentially the tip of the pyramid, essentially. Those are the rarest of the rare of these types of patients, but it's given us what we call proof of concept that this new treatment may actually be impactful in these forms of obesity. It's very similar, this disorder, to Prader-Willi once Prader-Willi children reach age 4 to 6. However, these children actually, even when they're infants, right as they're starting to breastfeed, they report extreme voracious feeding behaviors. The mothers say that they really didn't understand it at all, but they really gained weight from age several months to year, and they often show up at age year or 2 not knowing a diagnosis, unlike Prader-Willi, where a chromosomal diagnosis could be made, but they just have extreme overweight situations as 1 or 2-year-old patients. And as you can imagine, as parents, this is like a really difficult situation because you're sort of thought that it's your fault, but really it's not. It's the genetics of the situation, and now these genes are being identified, and we've embarked in trying to do a genetic screening of these rare conditions to see if we can identify patients around the world to see if they have this extreme early onset of a form of obesity. Here's patient treatment charts of the first 2 patients. And we've started with adults, as I mentioned. And so this is our very first patient we treated based in Berlin, Germany at Charity Hospital. We collaborate with Dr. Peter Kuhnen at the Charity Hospital in Berlin. And he, 20 years ago, he and his colleagues identified this POMC deficient patient that developed extreme obesity as an infant, and ultimately, at this time of this treatment, had been considering possibly bariatric surgery or other approaches, but weighed 155 kilograms as a 22-year-old female in Germany, and 155 kilograms, I guess that's about 330 pounds, and so she was extremely overweight, and she suffered from ongoing hunger. Unlike Prader-Willi, these patients are actually completely intact mentally. They don't really suffer any signs of intellectual impairment at all. So she was able to respond herself to a patient-reported outcome of hunger, just a simple 0 to 10 score. And her score was 9 to 10 at the beginning. And so when we started treatment, this is again an investigator-initiated trial where we just did it on a dose titration basis. We started at a dose of 0.5 milligram, and every week or so we would move up in dose. And we had, based on the toxicology results, we had permission from the German regulatory authority to treat for 13 weeks. And you can see the first 13 weeks, she actually had a remarkable response. In the blue curve is the hunger score, where it went from 9 down to 1. So her hunger really was remarkably suppressed. And she also began to lose weight. At 13 weeks, marked by the orange bar, you can see that that's where we had to stop treatment because we only had approval for 13 weeks. And she rebounded immediately and also had returned to all these unpleasant sensations. So we, together with Dr. Kuhnen, gained approval to start her treatment up again 3 or 4 weeks later. And you can see that the rest of the time course now going out to over 84 weeks, she's had continuing improvements in her weight on a stable daily dose of about 1.5 milligrams per day. So this is, again, was very exciting results to us. These data were published in the New England Journal this summer. And so this is patient 1. Patient 1 is one evidence, but now we had another patient that was from France that we had participate in this study as well. In a very similar situation. Here we gained approval to not have to do the withdrawal period because we just titrated at 0.5 milligram and moved up in dose. And you can see in this patient who started out at 152 kilograms, so a little bit less, but still over 300 pounds, and a very high hunger score, she had a very similar response. Marked suppression of hunger once we got to about 1 to 1.5 milligrams, and a gratifying reduction in the weight overall. And so this patient now, based in Paris, is at around, at 42 weeks, she's lost about 40 kilograms over this time period. So these were the 2 results of the patients that were published in the New England Journal. And it's sort of our proof of concept that we think we're on the right path here, at least for some of these genetic obesities. And our whole goal is to hope that this is also at play at Prader-Willi. I'll show you just one slide that shows you the kind of improvements that you get in insulin sensitivity that Neil talked about as well. These patients who are only 20 years old, they don't have diabetes per se, but they all suffer from extreme insulin resistance. And that's shown in these curves where at baseline, when you give them an oral glucose load, they really shoot up in the dark bar in the top, their output of insulin. Their pancreases are completely normal. They don't have diabetes, but they control their glucose by this extreme output of insulin from the pancreas. When you can see that when they've lost weight over time, which happens if you're able to lose weight from bariatric surgery or other means, you can also improve insulin sensitivity. This patient, patient number 1, also had improvements in their insulin curves at 13 weeks and later in the study at, I think it's 28 weeks. So this improvement in insulin sensitivity is an underlying sign that the metabolic factors involved in this patient is also improving. I'm going to move on to a Prader-Willi and tell you why we're thinking. And here again, this is where I have to update the figure. I have to add PC1 back in here because it may be related to the SNORD116 gene complex as we learned this morning. But our hope is that by acting here in Prader-Willi in a different kind of trial design that I'll show you, we're going to have similar effects on weight and hyperphagia. But I sort of agree with what Neil said. Hyperphagia is so important in this condition, and the FDA is hearing your voice on that question. They certainly know that weight's important also, so I wish Neil luck and trying to make that headway with the FDA. Whoops. All right, so here is our trial and what we're trying to do. The previous 2 patients with POMC deficiency, we just treated them. They had no control and everything else. And here, we're only going for about 10 weeks total treatment. It's a short-term trial. It has active arms as well as a placebo arm, and we're doing what's called a crossover, or a switch in the middle after 4 weeks of treatment. So with that kind of design, and especially now knowing the results we had in our POMC patients, we're not sure we're going to see much weight effect, but we're going to look very closely at an instrument that was derived from the Dykens score developed by Elizabeth and her colleagues at Vanderbilt. And so that observer-reported tool is what we'll be looking at to really try to understand hyperphagia and those kind of behaviors in this design. You can see that there's ultimately, some of the patients may get up to 8 weeks total treatment on drug, but others will be on and off drug, and we'll be looking at these data very closely. At this point, I'm happy to say that we are just this week finished getting the last piece of data, last piece of safety follow-up data on the last patient in this trial, so we expect to have results by the end of this year. So that's, again, good news. The one thing I can say about this trial is that we watch all the patients in terms of safety and tolerability. We've watched all the patients on a blinded basis because some are on placebo and others are on active drug. And generally, we've seen the same kind of experiences that we've had in the 200 patients we've treated before. We do have some side effect due to cross-reactivity to the skin receptor, MC1. It's the skin receptor that responds to melanocortin-1, and it causes pigmentation, normal skin pigmentation, so you can get a darker tan in this situation. We saw that in our 3-month study, and we've seen that in some of the Prader-Willi patients. But when the drug is stopped, the tan goes away, just as if you would no longer, if you were in the winter months and not exposed to sun. We also do get some side effects related to sexual issues. Males get erections occasionally, and females have arousal. We saw this in our healthy volunteer studies and the longer-term studies. We've had a couple of penile erections in the male patients in Prader-Willi, but that's really about it. And I'm glad to say that we've had really minimal effect on any blood pressure issues that were thought to be drug-related. And so we'll have more once the data can be unblinded and fully analyzed, and I will stop here and take any questions. Yeah.
Probably already said this, but how many people were in this study?
In Prader-Willi?
Yeah.
It's 40. We had 40 people all told. So, and what's that?
That's in phase 2?
Yes, it's in phase 2. And those are the data that we're going to get at the end of the year and know what our next steps are and what to do with, relative to what we've seen in the monogenic obesities. I will admit, since we're based in Boston, and we had like half the company here today, 5 of us, and in the back are Michelle and Kathy Folster, who are at the booth we have outside. We're not actively looking for new patients, but because we're in the midst of analyzing the data once we get the data from this trial that just is finishing.
So assuming you move on to phase 3, what numbers are you looking for?
Yeah, we expect, and this is where we have dialogue with FDA and European health authorities, that we will need to have, enough to satisfy, the benefit and risk questions that the FDA and health authorities ask. So we're expecting around the order of 100 patients. That's smaller than other larger populations, but it's what I think the precedent has been set with Zafgen to look at in the Prader-Willi population. We expect it'll need to be, like Neil was saying, 6 months of treatment. And the need for a placebo. One thing I will emphasize, based on what Jessica said earlier, these are rare patient populations, and your community is so active, and so the natural history information and registry information that you can provide now is so important. When you think about these other conditions that Rhythm is trying to understand to treat, we've only treated 2 patients, and they both got active drug. And so, of course, they want to know what's the natural history of this disease, and it's extremely rare. And so all of the information that you provide as a parent community on your children and for these rare diseases, it's what we need, because that gives us the information about what happens when the patients aren't treated. So. Yeah, question?
Were all patients in the trial overweight?
Yeah, they were. They were all BMI of 27 and above. And, you know, again, that's one of those, the group that reviews this disorder at the FDA is called the metabolic endocrine disorder. They are used to dealing with diabetes and obesity, and so that's in their mindset. But I agree with what Teresa is saying, that they're hearing a lot from your community, the Prader-Willi community, about the importance of hyperphagia. If it had gone to a different review division dealing with neuropsychiatric disorders, you know, they would have been hearing about hyperphagia and anxiety and other disorders. But in that context, I think they view weight as a critical component. Certainly our drug, you know, and drugs that are looking at weight and hyperphagia will have to look at the weight improvements. But in the context of, you know, the good parental control that's often, you know, occurring for patients that have this 4-year window before they know the hyperphagia is really going to kick in, you know, there are a lot of Prader-Willi children that have pretty good weights. And I know you're the most active and you have those kind of children, but you still have the behavioral problems. So I think we're going to try to continue to fight the good fight on those questions and see what happens. So, any other questions? Yeah.
Were you saying that you're not expecting to see the same dramatic weight loss that you saw with the POMC deficiency?
No, I'm not saying that. I don't know what I'm going to see. I just know, you know, that the complication, the disease is a chromosomal 15 disorder with SNORD and MAGEL2 that we've thought was interesting, fits in the hypothalamus somewhere. And so that it may be more complicated as a disease and a disorder, but it's also, we did a trial that is lasting, all told, 8 weeks of active therapy. And we know, if you look back at the slides, you know, if you go into the slides in the very first 8 weeks, oops, of this patient, why did it go off again? Okay. If you look at the first 8 weeks, this is actually pretty dramatic. But this is somebody who, you know, she was not necessarily being held on a, you know, she had free access to food. She's a 20-year-old. She's not surrounded by locked refrigerators and locked cabinets, you know, and so her weight was up at 330 pounds. And she was independent at this time. And so you can have a bigger effect. But, you know, over a 12-week or a 10-week period, which is right at the very beginning there, I don't know what I'm going to see in the Prader-Willi trial. And so that, you know, one of the things that we may have to plan, just like was done with other trials in Prader-Willi, is to do longer-term treatments to see that effect. Good. Any other questions? Well, again, it's a pleasure being here, and thank you again.